So we're recording, it is April. It is May 27th at about 1:30. We're going to start TherEx and finish off the exercises we kind of started with. Can everyone see the exercise on the side? Do I get a kind of nod? Okay, good. All right, so just to review, we're going to kind of do a real fast review down through these. Abdominal bracing, taking the abdomen, tightening it up, isometric, right? When we're looking at these, most of these exercises here are what type of an exercise?
Isometric.
ISO, right? Yeah, right. Those are our ISO exercises. Does that mean there is no movement at all? No, there's slight amounts of movement and it is perceivable, but for the most part, they're isometric exercises. Glute sets. Is Dr. Reskin in here? Dr. Reskin's not in here. Squeeze your butt. I have to watch what I say around her. She doesn't like when I say that.
Mr. McKeever?
Yes.
What's just like the whole definition for isometric again?
Yeah, so that's actually a really good question. Thank you. So remember, isometric in Latin, iso meaning same, metric meaning what? Length. Length or measurement, right? So isometric means the muscle stays at about the same length. So isometric means that a muscle is typically not doing gross movement. So if I put my hand here like this, and I want to work horizontal abduction, right? And I put resistance here, and I just push against my hand. Because I am not pushing out, I'm not actually getting movement, that would be an isometric exercise.
Okay, thank you so much.
That's different than an isotonic exercise, which allows movement. And what are the two types of isotonic exercises?
Concentric and eccentric.
Con and E. So let's say I'm doing abduction here. If I am bringing the arm up, am I doing concentric or eccentric?
Concentric.
Concentric, right? Because I'm actually going up and resisting gravity, right? And I'm doing a full contraction. I'm doing a shortening of the muscle.
And that's isotonic?
That would be an isotonic concentric exercise. Right? Isotonic means same movement is the best way to break it down. I don't like that term. That's why I usually do concentric versus eccentric, because isotonic breaks down into the concentric and eccentric, if that makes sense, the subcategories. So I'm going up, my muscle is shortening. That is an isotonic concentric contraction. Now, there are two ways I can get from here back to resting, is I can just let my arm drop. There's no contraction there, right? What's letting my arm drop do? What's controlling it?
Gravity.
Gravity. Yeah, gravity's just letting me drop. Versus if I slow it down and control it as I bring it down, now I'm doing an eccentric exercise. Because eccentric is a slowing down movement. I'm actually still firing. What's the muscle that primarily does abduction?
Supraspinatus.
Okay, supraspinatus, and one more.
Deltoid?
Yep, deltoid. Good, right? So specifically middle, right?
Yes.
So when I bring it up, I can put my hand in my supraspinatus fossa here, and I can feel that supraspinatus firing, but I really can come out here and feel my delt firing because it's really superficial, right? And then if I slow down and just slowly let it down, I can still feel that delt firing like crazy, right? Whereas you would think, oh, well, it's coming down. In reality, the lats are pulling it back into place, right? But the lats aren't doing anything because this is just gravity bringing me down. I'm going against it. Same tension. Yeah, changing length. That's a good way of looking at it, Brooke. That's a good way of looking at it. Does that make sense between the isotonic versus isometric? Just to make sure. That's actually a really good question. Thank you, Brooke.
Thank you.
Yep. Ham sets typically done in hook lying, right? Yeah, their feet kind of dug in. There's their body, and they're doing the motion of the heel slide with actually out sliding. So they're kind of digging that heel in and pulling back and getting those hammies to tighten up. Quad sets. What muscle are we doing there? Gee, I wonder. Quads, right? And remember, because of the position we're in with quad sets where the leg is straight, it's not so much rectus, it's more of the true vastus group that you're working with there, right? So that's a lot of vastus work. And the quad sets are really good for building up a little bit of that, what's called TKE. There we go. I can speak today. Does anyone know what TKE stands for?
Total knee extension.
Close. Really
Terminal.
close. Terminal.
Terminal knee extension.
There we go. So terminal knee extension, meaning the last part. And especially in patients that get ACL repairs, a lot of them lose that final bit of knee extension. So quad sets are really good for kind of getting that last bit of knee extension going. Adduction squeeze, well, we're working our adductors, we're squeezing our legs together. Ankle pumps are moving those quads and also the, not quads, gastrocs and the tibialis anterior, because you're kind of rocking up on your heel, down on your toes, up on your heel, down on your toes. Also good for getting the blood pumping down in that lower leg to prevent what?
DVT.
DVT, good. Ankle rotations are just kind of the wig wags, like I said, turn your foot out, turn your foot in. Supine heel abduction slides, all the way out with the leg, back in with the leg. Heel slides are true knee flexion where you're sliding it back towards your butt. What was the difference between short arc and long arc quads again?
Short arc has the bolster underneath.
Good, it's a bolstered, right? And about how far are you going with a short arc quad?
45 degrees.
Yeah, about 45. Now, is that perfect? You have to break out the goniometer and get exactly, no, it's not perfect, right? But about 45, whereas this is 90 or greater, right? Now, like if you're sitting with the leg under the chair, you're going to get greater than 90, right? But 90 or greater-ish. It's an exact science, I promise you. Straight leg lifts, exactly like it sounds. It's a hip flexion activity. Straight leg lift with abduction or with internal rotation are used to kind of build up control of that hip muscle. Four-way hip includes a straight leg lift, but adds also extension, abduction, and adduction. Talked about prone hamstring curls, supine fallouts, or an eccentric activity where you're sitting kind of that clamshell position and let your leg drop out, versus sideline clamshells where you sit here and you open up the clam and you close the clam, and you open up the clam and you close the clam.
Mr. McKeever?
Yes.
Would you ever do like, because I've kind of seen this done, it's more like isometric work, but it's like knee extension isometric, like just kind of seated, and then like they're like off of, like it's facing towards a table.
Okay.
And they're kind of just pushing that like forward, like towards the extension
Sure.
of the knee. Is that something that usually is still done, or?
Yeah, I mean, anything. So and the theory behind that is, again, we talked about this briefly, is the problem with any type of knee surgery or stuff like that is losing extension. I'll be 100% honest. Any activity that works towards extension, do it. I mean, anything you can, because it's really hard once they lose extension to get it back. One of the big things I like to work on when I have somebody that's lost extension is walking backwards. Because when you take a step backwards and straighten the knee out, you really have to accentuate that extension. So you could do that. The other thing I do with a lot of patients when I'm working on extension is I'll have them do a quad set and I'll put a 15-pound cuff weight on their knee. Because that way, as they're doing the quad set, that 15-pound cuff weight's pushing down too. And it gets them a little closer to extension. So yeah, anything works. Anything is fair game, as long as it's safe.
Do you ever kind of get like worried that it's gonna lead to like hyperextension at all, or do we don't have to worry about that?
Well, so here's the deal. If you're talking about somebody with a pathological condition like a surgery or something like that, probably not. The likely, if you get to hyperextension, you have worked them pretty hard. Okay. Most people, even after an ACL surgery, will end up losing at least 5 degrees of extension, and it's just kind of a permanent. Now, 5 degrees is going to kill you? No. Right, and 5 degrees we'll learn in goniometry is kind of within discrepancy range, so it's not even, it's hard to really quantify 5 degrees, right? But yeah, no, you're not. Now, let's say I'm working with Stephanie and she's healthy, normal individual. Maybe she's just coming in because she has problems. I don't know. We're working on sports type therapy with her. Yeah, then I have to be a little bit more careful because she actually has already existing flexibility and stuff like that. I got to watch that I don't hyperextend that knee too much. So maybe if I'm working quad sets, then I might put like a towel roll or something under her knee so that when she pushes down, she has some resistance, but it also keeps her from hyperextending that knee, if that makes sense.
Okay, makes sense. Thank you.
Yep. All right, so we've finished with sideline clamshell. So now I'm going to switch cameras here real quick. I'm getting really set up here because I've got now 5 cameras. All right. So,
so do you want us to do these like exercises?
Well, I mean, yeah, if you practice with me, it's great.
Okay.
I'm not keeping track of you for this. Somebody else asked yesterday, why are we doing these virtually? That was a really good question. Why am I doing these virtually? Because I want to teach you them, because guess what the first day we're going to do in lab is? All of these exercises, right? So if I teach you them now, when we go into lab, you can literally get right into teaching them to your partner and practicing with your partner. I don't have to reteach them. Does that make sense? That's why we do this virtually first. So seated marching. Who do you think this would be good for?
Seniors, elderly patients.
Good. This is a really low impact one. I heard another one. What was the other one?
Hip patients.
Hip patients. Good, right? As long as we're not violating their precautions. So seated marching is exactly like it sounds, right? Our feet are going to be nice and flat, sitting up nice and tall, and we're just going to so we can do one leg seated marching. We can do 2 legs seated marching, right? And I'm just going to march my way downtown, right? Now, the higher we bring the leg, the more it's going to require hip flexion, but the more it's also going to require, if I'm sitting this way so you can see, the more it's also going to require me to have some eccentric control as I bring it down, right? Where do you think, so as far as knee flexion when they're seated, where about do you think you want that knee flexion seated?
90.
About 90, yeah, right? Because if I'm down here where I'm way past 90, it's a lot harder for me to get there, and I've already lost some of that hip flexion. I may even bring them up where they're kind of a little bit out of 90, so maybe here, so that I have more hip flexion that I can bring them into, right? Just depending upon what I'm going for. Now, this also begs the problem because this is rapid alternating movement when we're marching. Even though it doesn't seem very rapid, it still is considered that because I have to have coordination. If I say right leg, left leg, right leg, left leg, right? There has to be some cognitive stuff going on in their brains. Does anyone know what the term is if they have a problem with that alternating movement?
Is that like a stroke?
Could be a stroke. Stroke can lead to it. You're exactly right, Brooke. Good idea. There's a medical term for that. And I'm going to probably butcher the spelling here. Just watch me.
Neurodegenerative.
What's that?
Neurodegenerative disease? I don't know.
Could be a neurodegenerative, right? Dysdiadochokinesia. Actually spelled it right. Look at that. So dysdiadochokinesia literally means difficulty with rapid alternating movements. Never would have guessed. That's okay. I was seeing if Dr. Sokel talked about this, and evidently she didn't, if this is the answer I got here. This is a common problem. This actually gets tested for quite frequently. I'm going to just leave that on there for right now. This gets tested for quite frequently by what type of authority?
Neurosurgeons.
Okay, neurosurgeons, good. But I'm thinking more in the community. By the police. Does anyone know what tests the police do that might test rapid alternating movements?
DUI check.
What'd you say?
DUI check.
DUI check, very good, right? Move down where you can see my face, right? One of the tests that the cops have you do is put your arms out wide and touch your nose. That it goes along with marching, and they can have you march actually for the DUI checkpoint. that's still testing for dysdiadochokinesia. So I'm going to take this a step further. What part of the brain handles coordination?
Cerebellum.
Cerebellum. Good. So what do you think alcohol affects in the brain?
The cerebellum.
Cerebellum. Good. Right? So they could have you stand up and march. And if you have a normal person that stands up and march, right? If I put this tape kind of between my legs here, right? If I stand up and march, I should stay fairly well within my marching, right? Pretty close to the tape, would you agree? Yeah? Now let me show you something because of all the concussions I have a slight cerebellar ataxia. So I'm going to close my eyes. You guys can't see this, but trust me, I'm going to close my eyes. Now watch what happens. I'm going to move my chair. So closing my eyes. Yeah, I didn't finish where I started, did I?
No.
Right? That's because the alternating movement messed that up. Right? So seated marching is why we do it seated to start with, because what if we got an old person up and they did that and we're like, whoa, they're all over the place. Better to start seated, right? So what do you think the progression then would be? Standing, right? We can move to standing to add balance to it. How else can we progress seated marching?
Supine.
For like longer period.
Okay, we could add resistance. We could do it supine, absolutely. We're going to talk about some ways to do it supine, right? So there's all kinds of progressions we go through. All right, seated diaphragmatic breathing. This actually is really good, and this is more of a relaxation technique than it is anything. So this one may feel good to you all so that you can kind of relax. So when we do seated diaphragmatic breathing, and we can also do it with arm raises. When we breathe with our diaphragm, where are we breathing with? Our chest or our belly?
Belly.
Belly breathing, good, right? And Amanda, did they ever teach us not to breathe with our belly in the military?
Yeah.
Oh, yeah, right. Suck that belly in, breathe with your chest. That's bad. I don't know why we do that. It looks good because you got a nice tight core, but in reality, you can't breathe anyway because your diaphragm is here, not up here. So diaphragmatic breathing, you have to relax your core, right? So you have to get nice and comfortable. We're going to start with diaphragmatic breathing. So I want you to put one hand on your chest, one hand on your belly. Belly. With the diaphragmatic breathing, you're going to take a deep breath in through the nose and then breathe out through the mouth. I like to tell my patients, smell the roses and blow bubbles. We used to say blow out the candles, but blowing out a candle is like this. Whereas blowing bubbles is a nice control, breathing out. So, and what I want to feel is you want to feel your belly rise before your hand rises. So let's start with that. So just put your hand there. We'll do 3 of these. Take a deep breath in. 2, 3, and breathe out. 2, 3. In. 2, 3. Out. 2, 3. And one more time. In. 2, 3, and out. 2, 3. All right. Now we relaxed a little bit. Feels good, right? It's nice and comfy. So now we're going to add arm movements in with it. And there are a couple different some people just come from here and bring them up like you're riding a roller coaster. I tend to go from crossed arms low to open arms wide. You'll guess that. I wouldn't go that far. I'm not that great. So I tend to tell my patients, make an X down by your legs. And what we're going to do is when we bring it down, we're going to take our deep breath in. And when we go up, we're going to take our deep breath, our exhale. So I'm going to start down here. Exhale all the air out of your lungs. And breathe in. And breathe out. And breathe in. The goal of it is to expand the chest. That's why we're coming up out here. If I try to breathe in when I'm out like this, is it going to be hard for me to breathe in? My chest wall is all expanded. It's really hard to breathe in out there. So there's all kinds of techniques you can do with this, but the point of this one is a relaxation exercise. I like this when I get a patient that's really nervous and I'm getting ready to get them up and walking maybe for the first time. And you can tell they've got that little shake going on. They're kind of nervous about getting up. Let's do some breathing exercises before we get up. I can still build for that because that is an exercise. And the good news is it gives them a little bit of confidence going, okay, I'm more relaxed. I can do this. Namaste. Namaste in bed.
Mr. McKeever, is the chest the reason why you do it in that order? Because I've only ever seen it the opposite way.
I tend to do it in that order because of chest. Now, if you do it the other way, do it the other way. There's not a right or wrong way. The only thing we found out, how many of you guys, were any of you runners in school? Like cross country or track?
Yeah.
Okay, how did they tell you to stand to recover your breath?
Put my hands over my head.
Like this?
My nose, in through my nose and out through my mouth.
Yeah, well, guess what we realized? This is wrong. You can't really breathe effectively like this. And if you look at the new kind of kinesiology stuff, they have you more in a tripod position, leaning forward. Like if you're standing, obviously, recovery position's more like this now. Because in this position, you're actually letting gravity help expand that diaphragm. Yeah, people always yell, and why do we, and here's the SQP. So why do we do that? Well, because it was, again, similar to the military, right? Military, suck in the belly, chest out, look tough. Football, same idea, right? But in the new textbooks, recovery position is that way. If you tell a patient that's got COPD to put their arms behind their head and breathe, they're actually going to get short of breath almost instantly. So recovery position, if we're seated, recovery position is here. Kind of leaning forward, elbows on, taking some deep breaths in. In this position, my chest has plenty of space to open up, right? Try it next time you're angry. Yeah, it does, right? Also using accessory respiratory muscles, excellent. Next time you're angry, just try it once. Put your arms behind your head and do some relaxing breathing, and then go into that tripod position and try it. You'll find you relax a little bit more in that tripod position. All right, so now we're going to do some fun ones. Now we're going to do a little bit of foot exercises. So I've got my nice, where is this from? Kaiser University. I have no idea where this came from. I think it was at an event. Towel scrunchies. So towel scrunchies. Did anyone ever see this in the clinic where they work the intrinsics of the foot?
Yes.
Okay.
Yeah.
I typically, so it depends. It depends. So Brooke asked, exhale, arms out, right? Depends upon what you want to do. I do exhale, arms out, but there's not a wrong way, Brooke. If you choose to do exhale, inhale, arms out, then do it. The goal of that exercise is not so much, I mean, I have logic behind mine, but the goal of that exercise is what for the patient? With the relaxation, yeah. So whatever relaxes them. You could not even do the arms if you don't want to do the arms, just do the diaphragmatic breathing, hand on the belly and chest. That's okay, Riley. That's okay. That's why we're kind of working through this. All right, so for foot scrunchies, we find out, what do you think is a common problem with people's feet? That may keep them out, what'd you say?
The arches?
The arches, good, right? May keep them out of the military because they may get what?
Plantar fasciitis.
Plantar fasciitis and flat-footed. Good, right? I have a really, really, not only fat foot, but I have a really flat foot. I don't know if you guys can see the size of my foot, but like the side of my foot extends out way past my toes. My foot is a 10.5 4E, which means basically I wear boats. And I can walk on water almost as good as a duck. One of the problems is a collapsed arch. How do we work those collapsed arches? By getting the intrinsics of the foot to work, right? Your hands have intrinsics. Your foot has intrinsics too. Does anyone remember the name of the intrinsic muscles of the hand? There are 2 sets. So the intrinsics would be muscles that are in the hand itself.
Palmar longus.
Palmaris longus actually is outside. That's an extrinsic because it starts up here, right?
Extensor digiti minimi?
Outside. Extrinsic are the ones that start up in the forearm or down in the latter part of the forearm. Intrinsic start only in the hand. Do you guys remember looking at a picture with the little feather muscles in the hand?
Mm-hmm.
Adductor pollicis.
Technically, actually, you know what? I'm not going to argue there. Technically, yeah, it's technically an intrinsic, but that wasn't where I was going. So you got me on a technicality there. So inside your hand here, you have a couple set of muscles, 2 sets. You have the interossei and you have the lumbricals.
Wait, which part of your hand?
Inside. So in the palm itself.
Okay.
Here. That would be your intrinsics. So in here between each finger, you have interossei. What do those muscles say they are?
In between the bones.
In between the bones. Good, right? And lumbricals are the muscles that let you make duck face with your hand. They're responsible for what's called tabletop on your hand. Right? And what does tabletop with my hand look like if I was to convert it to my foot? Does it look like an arch? Magic, right? I'm just kidding. So your foot also has interossei and lumbricals. Those are your intrinsics of your foot. Oftentimes we ignore them because how many of you guys worked your interossei the last time you went to the gym? I know Jason did. Jason works his interossei every day.
Never skip it.
Never skip it, exactly, right? So with towel scrunchies, and you can actually do the same thing with hands, and I saw somebody said marbles and stuff like that as well. All you're going to do is have them take and squeeze their foot up and make an arch, and then they're going to relax it out and flatten out. And bring the foot back and arch it up and bring it out.
Is there a hold on that, Mr. McKinney?
You can, absolutely. Just don't hold it over 5 seconds because what do you think happens typically if you hold it over 5 seconds?
Locks up.
Cramp.
Yeah, cramps. Cramps. Try it for yourself once. Let's bring it in and hold it for 10 seconds. So do it to yourself. Squeeze your foot up. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and relax it out. Did that bug anybody? It bugged me. I don't like that. I do not like that. So what do you think? So this is just to work those intrinsics. What do you think a progression of this might be?
Making the item smaller.
Good. Making the item smaller. What else could you have them do?
Like what Anthony said, right? With what do you call that? Like marbles.
Good, right? Marbles. One of the things I love to do to my patients is make them do this. Okay, so scrunch it up, pick it up, and move it. Put it down, relax it out. Scrunch it up, pick it up, move it. Oh, sorry, Amanda. Thank you for spelling that out for me. Lumbricals. I like my lumbricals. Lumbricals are my favorite muscles. Right? Is that more difficult to do something like that? Because we don't pick things up. Well, I mean, I pick things up with my feet. How many of you guys admit that you pick stuff up with your feet? I do it all the time. Yeah, right? And I think that's from martial arts for me, because we had days where we were supposed to do stuff with our feet and it just becomes habit. And people, I know my wife who passed away used to be like, stop picking stuff up with your gross feet. They're not gross. My feet are beautiful. Now, the other thing we can do with this, and the same thing we can do with the hands, we can identify stuff with our feet. I could put a marble and a penny and a pencil down like that, obviously not a sharp pencil, and tell the patient to feel and tell me what they feel on their foot. What patients might have a problem with that?
Diabetic.
Diabetic, yeah, right, because they get that diabetic neuropathy in the feet. And that can help us tell if they've got some problems. Does anyone know what that's called if you identify objects by touch? It's another fancy term. And it's definitely none of you something tactile. The good news is you will never guess this one. Oops, I spelled that wrong. Hold on. I messed up the E and the O. When I see that word, I think it's something listening. Wouldn't you guys? Stereognosis. Like I see that, I'm like, listen to music, stereo. But that's the identifying stuff by touch. So like if you see somebody in a hand therapy clinic and they're sticking their hands in rice and they're like, I found a marble. Oh, I found a jack. That's what they're testing for. It's actually a pretty cool thing. So towel scrunchies. Okay, so we did our ankle pumps, right? The progression for ankle pumps is now standing heel toe raises. So I'm going to get myself nice and planted and try to get my feet in normal feet position because, hold on here, let me see if I can. And then you do that. That's normal, right? Standing heel toe raises. We're going to come up on our toes and rock back on our heels. Up on our toes. Well, that felt good. That was a nice crack. Back on our heels. Now, what if I have a balance patient? What do I want to make sure of?
That you're holding their hand.
Yeah, holding their hand, you got the gait belt on them, or at least if they have something they can lean on, right? That I can come over here to my table or my bookcase and lean on it. Please don't fall over a bookcase. I know there's a lot on me. Which part do you think a lot of people have the most trouble with that? The toe raises or the heel raises or the toe raises?
Toe raises.
Yeah, why?
Balance.
Yeah, balance, right? Coming back like that is not normal. And the other thing is we don't, so at the gym, we have all kinds of exercises to work, you know, toe press, everything like that. We don't have a dorsiflexin exercise, do we? Really? And there's not a machine that you can go to. Yeah, so you get a weak TA. Good. So if you wanted to go to the gym, if you wanted to be a healthy person right now and you wanted to go to the gym and work your tibialis anterior, how could you do it? Okay, TheraBand, good.
Knees over toe guy has a really good way of doing it. You like put your butt against the wall and just do tibialis raises.
Yep, good. The other thing I like to do is I like to just sit in a chair and take like a 25-pound plate, set it across my toes, and just lift up with that 25-pound plate. Yep. Now, how could you do it? This is what they patients say, why do I have a 25-pound plate at home? I'm sure you have a book. Put a book on your foot. There's ways you can do it. All right. Mini squats versus squats. What's the difference?
Range of motion.
Range of motion. Good. So there I go. I picked something up with my foot. Didn't even think about it. So a mini squat. How far do you think a mini squat's going to go? I'm going to tilt this up just a little bit. There we go. That's a little better.
Like 45 degrees?
Yeah, I usually think 45 or under. So when you're doing a squat, how wide should your feet be?
About shoulder width apart.
About shoulder width to shoulder width and a half, depending upon what you're going for, right? I like shoulder width and a half if I've got weight on my back because it just gives me a little bit easier space. But at least shoulder width, right? Ideally, when I do these with patients, I like to have either a chair behind them or them against the wall. And the reason I like the chair behind them is because that gives them a guide. Because I'm not looking for them to do this, right? A true squat in physical therapy is more like you're sitting down in a chair. So your butt is going backwards. Because again, what do you think we're working on? Controlling sitting down. So a mini squat, we're going to come down to about 45 and back up. You can add arm motion in. And back up. And back up. Versus a true squat is coming down to about what? How far?
90.
Down to 90. Good, right? So I'm going to come all the way down till I get to that kind of 90-degree point. And that gets tight for some people, right? Getting down to that region and then getting back up. How could I change that into a isometric exercise then?
Hold it when you're in the squat.
Good, right? So I can come down to my squat and I can hold.
With like wall sits. Also.
Like wall sits, good. And just being down there for that, was it probably 5 seconds? My legs are like, ooh, I didn't like that. Today was leg day. So my legs definitely did not like that. So the only thing I'll say about squats, and this is not attacking CrossFit, please don't think that. I do not like butt to floor squats. It puts way too much pressure on all of the structure of the anterior surface of the knee. And most of the people that I've seen for ACL tears that are not athletes are people that have done CrossFit and are doing those squats where they're like, yeah, my instructor told me to go down like this. And then come lunging back up. Right? You do that and you put a ton of force on that surface there. And it's just really easy to tear stuff. Now, your rear knee, just as good. Now, does that mean they're wrong? Well, yeah, no, I'm just kidding. I would question what their research is on it. Football coach. Trust me, John, you'll find that football messed us all up. I'm just saying. That's why I get hit in the head so much. So just be careful. If somebody's telling you that stuff, look at your research, because you'll find those really deep squats really hurt your knees. So if you're doing them and you're not having problems, excuse me, kudos to you. It tears my knees up. All right, side step lunge, and actually anterior lunges too. How would you tell a patient to do a side step lunge? Anyone have an idea?
Like a light bend on the knee and then just step side to side.
Good. And when you do that, what is it? So if I'm stepping to the right, my right knee is going to bend, my left knee is going to do what?
Push off.
What's that?
Oh wait. Extend.
It's going to stay extended. Good, right? So I'm going to step out, and again, force of habit with martial arts. Sorry about that. I have a habit of bringing in and going out. But if I'm stepping out, I'm going to step out and lunge out. Now, what do I not want to happen?
Your knee over your toes?
Yeah, I don't want this.
Mm-mm.
Ow. That was my hip. Right? So you want to make sure. Come out, controlled, knee to toes, and back. So when I come back, what does that require for me to come back? Does that require a combination of my adductors and my abductors working together? Because think about it. I got to pull back with this, and I have to slow it down in here. That's a lot of work. So that's a side step lunge. What about an anterior lunge or a front lunge? There are two different types. So you have the straight leg, where you step forward, same thing as the post side lunge. Lunge here, straight leg, come back. Knee, toe, back. Or the other one you can do is what? Bent knee lunges. Has anyone done those? Where you're going to come here, drop down, and back. Now I lost control there because I don't want my knee to touch. Wow, that left leg's killing me. Should not have done leg day today. Right, so step forward, then down and back. And you see how bad my feet are.
Did you say that your knee is touching the floor?
You want to control it not to touch the floor.
Okay.
So, with those, both squats and lunges, what patients are we going to do those with?
Athletes.
Oh, I heard it. What?
Athletes.
Athletes. Good. Right? Post-surgicals, like your ACLs, LCLs, MCLs, medial meniscus repairs. Just focus when you're doing it. If you let those knees go beyond the toe, again, look at how tight that surface is there. That's going to put a lot of pressure there, and they do it one too many times, and pop, off goes the ACL.
Could you list off the surgeries again, the post-surgeries?
Sure. So like ACL surgery, well, actually all the L's. So ACL, PCL, MCL, and LCL surgeries. So the whole, so ACL, PCL, LCL, MCL. So all the L's. And then typically medial meniscectomies. So medial, I'm going to use the other hand. So medial meniscus is right about here. Now, one thing, if I do an anterior lunge, so I'm going to do it with my right leg, then I'm going to do it with my left leg. Watch my tibia on each of them. So I'm going to step back a little bit. So when I do a right leg lunge, see how controlled that tibia is? Yes? I'll move my hand. Tibia control. Now I step out with my left. Ow. My ACL is torn. It's not repairable. And I've just never had it fixed. So be aware of conditions your patients have. If they tell you they've had a tear or it's actively torn, maybe back out of the lunges and squats until you get clearance from the PT. That's all I'm saying.
Is the PT going to give someone with external rotation like yours movements like that, or are they just going to skip that?
Typically, they're going to skip it and go on to something more controlled like a weight machine or something.
Mr. McKeever,
Yes.
what about someone who has like severe case of scoliosis? Because I know somebody who has it, and when they do like a lunge on one side, they're okay, and then when they go to the other, they like almost fall over.
Good. If you have that with a patient, gait belt them. They can still do it. It's just they have to learn to control it a little differently because they've got muscle imbalances, right? So we have to teach them to control it differently.
Okay, thank you.
Yep. Okay, terminal knee extension. Kind of one of the last knee stuff. Obviously, you need these exercises. Terminal knee extension, you're going to kind of start in almost an anterior posterior stance. In the martial arts, I'd almost call this kind of a straight front stance. I just want kind of the knee relaxed. And my terminal knee extension is I'm going from about here to locked up to back out. Locked up, back out. What muscle am I working here, primarily?
Your quads.
Okay, quads. Which one?
Rectus femoris.
A little bit.
VMO.
Your vastus medialis.
Vastus medialis, particularly which part of it? Vastus medialis oblique. So, vastus medialis, or the VMO. Good. What's the VMO's job? Does anyone know? Other than terminal knee extension, that's not the answer I'm looking for.
Does it help stabilize the knee from Vegas?
Okay, good. So here's my kind of quads, right? So I have medialis, lateralis. What's the big one in the middle called?
Vastus femoris.
What's that?
Vastus
Intermediate?
Intermedius, good, right? And then I've got, here comes my rectus, right?
Yeah.
Down, so the way they pull, the medialis kind of pulls like that in an angle. Down here at the very base of it, you have some fibers that go this way. That is your VMO. Some science will say it's not a separate muscle, and some science will say that it is. The job of the VMO is to control that little bad boy. What's that?
Patella.
Patella, right? The main job of VMO, main job of it is patellar tracking. Meaning making sure the patella stays in its groove, and when you get to lockout, it stays where it's supposed to be, right? You can see, can you see the little bit of fibers there kind of pulling on that patella? Right? So when I come out and I lock, there's a little bit of oblique fibers pulling kind of medially. Who has a problem with patellar tracking? Guys or girls?
I would say girls because of their hips.
Very good. Brilliant answer, right? Does anyone know what the condition is that females suffer from more than men because of their patellar tracking? PFPS. Does anyone know what that stands for? You can guess what the first word stands for. What's the first word do you think stands for?
Posterior?
Patella.
Oh, whoops.
Right? So it's patellar femoral. So we're dealing with the femur. Pain syndrome. Any of you ladies that run, does your knees ever really hurt after you run? Like they get kind of sore, especially if you run long distance?
No.
No? Okay. Bianca's like, yeah. It's a really common condition of ladies, unfortunately, is because of the way that we're going to talk about the Q angle at the hip in a little bit in kinese. But because of the Q angle at the hip and the way the hip is designed on a lady, it affects the pull of that VMO. Yep, it hurts outside when I would run. Good. And Joe says that's why I'm going. So yeah, doesn't mean guys can't get it, Joe. It's just less common in guys than it is women. In men, the common thing we get is what's called Osgood-Schlatters disease. And I'll spell that because I know that's going to be Brooke's next question.
Is that more common in children?
It is more common in young men, yes. So going into adolescence men, right? Because what that is that tibial condyle, or not condyle, what am I looking for here? Oh my God. Crest, there we go, I can think of it. Where that tendon attaches gets really big. It grows faster than the rest of the tibia. And so that affects the pull of that tendon. And boys will complain, oh my God, my knee hurts and it's right here. And you look at that and that's all bright cherry red and inflamed. So ladies typically get PFPS. Men typically get Osgood-Schlatter. And even older guys can develop Osgood-Schlatter, but it's primarily a disease of kind of younger boys.
And what is that again?
So Osgood-Schlatter is, it's an overgrowth of the tibial, is that crest what I'm looking for? It's not crest. Yeah, I think it's crest.
Tibial tuberosity.
Thank you. There's the word I appreciate it. My brain was not working today. Tibial tuberosity. So it's where that, right there is my tibial tube, right? That big bump on the front of my knee. I had it when I was younger, and man, this is now adult size, but I think when I was 12, it was about the same size. And so that really affects the pull of that tendon and makes it really painful.
And how come that happens?
Just a growing disease.
Oh, okay.
It's just what it literally is just for whatever reason, that part of the tibia ossifies faster, if that makes sense. There are some research out there that maybe the growth plate of the tibia closed early on that boy, if that makes sense. But go ahead.
Sorry. So if that's the case, so like you said, like even later down the road, like even like older men develop that, like is that more like calcification, or is it more
In
like?
older men, it would be calcification. Exactly. Good thinking. Right.
Okay.
A lot of times, guess what it comes from doing? Too many squats or too many butt to floor squats, where they're really stressing that tibial tube. If that makes sense.
Okay.
Right.
Can it happen from jumping?
What's that?
Can it happen from jumping?
Yep, right, from plyometrics, sure thing. And for kids, that's why a lot of times, and we'll talk about that in research and weight training, that's why a lot of recommendations are not to do weight training with kids, because their bones aren't ready for it, right? Although we see all those, like the advertisements, like the world's strongest little boy, and I'm like, why did you do that to your kid? All right, are we okay on knees now? Incline hiking could be, yeah, I didn't think about that. Little Hercules, there we go. Hercules, Hercules, Hercules.
Yeah, that kid was on Anavar. That's why he was that way.
Yeah.
Found that out.
All right. So let's talk now. Let's get down to the pelvis, because the last ones we're going to have are kind of pelvic exercises. Pelvic tilts, APTs and PPTs. What do those stand for?
Anterior and posterior pelvic tilt.
Anterior, posterior pelvic tilt. So I'm going to try to move my chair over first before we do them kind of laying down. So that's not going to work either. I'm going to have to stand up. Tilt the camera just a little bit. There we go. All right. So with pelvic tilts, I'm going to use my ASISs as my guide. Okay, so there's my bony ASISs. Don't poke like this with your patients. Big, nice hands. I just know where mine are. In an anterior pelvic tilt, which way are my ASISs going to be pointed?
Like up in a forward.
Okay, they're going to be pointed forward, which is more actually pointing which way?
Down toward the floor.
Down to the floor, right? So if my ASISs are pointed like this, in an anterior pelvic tilt, they're pointed down. Posterior pelvic tilt, then guess which way I'm going to go? Up, right? So, and remember, this is not thrusting of the butt, which is what patients are going to do. The butt is fairly standard. It's literally just pelvic work, right?
Mr. McCary, can you go to the side if you don't mind?
Yep, I'm going to right now.
Oh, thank you.
So again, my ASISs are here. And if you look, I've got a little bit of tilt because I'm actually lining them up with my ASIS. I've got a little bit of anterior tilt to start with. So anterior tilt, rocking down. What am I creating up here in my lumbar region?
Lordosis.
Lordosis, good. When I do posterior tilt, right, so now I'm going to tilt them up. What happens to my low back?
Straight.
Yeah, it straightens out, it flattens out. So think about somebody that's got low back pain. If I have them doing those posterior pelvic tilts, it's going to stretch all those spinal extensors back there and make them go, oh, it feels so good. Because I've been standing like this the whole time. Oh, I was like, wait, what are you talking about? My dad? No, just kidding. All right. So normally when we have patients do this, we're going to have them on the floor. Right? So they're going to lay back on the floor here. I like to have them put their hands on their crests. And I'm going to first do it with them. So I'm going to put my hands on their crests, and we're going to do anterior, and we're going to do posterior. And again, we're not doing this. There's no bouncing of the butt. It's literally just rocking. Maybe 2 to 3 inches of motion, if that. It's not a ton of motion. Does that make sense? So in reality, we're going to talk about, and Kenny's talking about the diamond of the pelvis in a little bit. But when I do that, I'm going to be working those force couples to cause my pelvis to tilt one way or the other. Most people are stuck in kind of an anterior state. So we need to start working those posteriors to kind of help that low back out.
Could you demonstrate it one more time, please?
Sure, I can. Absolutely. I love demonstrating pelvic tilts because it's so much fun for you guys to make fun of me then. I'm just kidding. So here I am. I'm as neutral as I get. So if I do an anterior, my pelvis tilts down. I can now look at this. I can slip my hand under my low back, right? Versus a posterior, now I'm going to tilt towards my head. My low back's flat. I can't. For whatever reason, these are super simple exercises. Oh, I can. Would that help you guys? I didn't even think about that. I apologize. Stop share. Good call, John. See, that's why I keep you around. Ow. All right. So, pelvis tilted as neutral as possible. Anterior tilt. I'm tilting my pelvis down. I've got space now. And you can put your hands back here on your back. And then when you go to a posterior pelvic tilt, you should feel your back come into your hands. These, for whatever reason, are the hardest exercises to teach a patient. They can learn every other exercise in the book. You can have them doing like plyometrics. For whatever reason, pelvic tilts they don't get. So what I tend to do is I will do them with my hands on. So I will manually rock their pelvis the first couple times. Tell them, relax for me. Yeah, they are good. Absolutely, Brooke. The exercise was so hard for me, exactly. They're really hard for patients that have low back injuries, just because of how tight that low back gets. It's really hard to relax it, which is why a lot of times I'll tell the patient, I'm going to put you on heat, so I'll have them lay on a hot pack. How many layers? If they're laying on it? 8 to
10.
8 to 10, right? Or 1.5 inches minimum, right? There, sorry, 1.5 inches minimum. How much do you need if it's laying on them?
6 to 8.
6 to 8, or what's the inch range? 1 inch. So 1 inch for on them, 1.5 inches for laying on it. See how they came back to modalities? Look at that. I'm special. But now, so let's say Diana had a problem with this. This is saying it's hard for her. So I now put a hot pack under her. Right? So Diana's laying there. She's like, oh, this is heaven. I love this. And now I come in and I show her how to rock her pelvis. I tell her, relax for me. When she's on the hot pack, she's nice and relaxed. I find for whatever reason, when they're on the hot pack, I can get them to do pelvic tilts a lot easier. I think it's because they're able to actually finally relax that back out, right? Yeah, they can be good for a pregnant woman for sure, Brooke, especially if a pregnant woman has sciatica. It can help relieve a little bit of that sciatica. So now everything we do after here, we are doing a pelvic tilt first and then doing the activity. So I'm going to turn this way, I think, so I can see better. So the first thing we're going to do is marching with pelvic tilts. And if you notice, it's always with posterior because we live in an anterior world. So I'm going to posteriorly pelvic tilt, and then I'm going to march. And the main goal is for me to hold that pelvic tilt. Oh, I fell out. Okay, so I got to get back. Posterior pelvic tilt. Hold it, hold it. All right, I dropped out. So I'm dropping out at about 4. So I've got to concentrate a little better. Hold that pelvic tilt. Hold that pelvic tilt. How are you going to know if I'm holding it as a clinician?
You can look at the space underneath their back.
Space underneath my back, good.
You could use your, I mean, if there's no hot pack there, you could use your hand or a cuff.
Good, right? Yeah, blood pressure cuff works great. Right? I like to inflate a blood pressure cuff slightly and slide it under their back and watch the needle move. Because when they lean back, it's going to put pressure on the blood pressure cuff and the pressure is going to go up. Right? Does that make sense? So I may even give them the sphygmomanometer, the little dial, and say, I want you to keep it at 40 pounds. And that gives them a visual cue, doesn't it? They can look at it. The other thing you feel is you feel their abs, right? Are their abs nice and contracted? Yep, you are engaging your abs. Good. That's where you. How did you know I was going there, Stephanie? Are you getting in my head? It's kind of scary. It's scary up there. So yes, I'm engaging my abs. So maybe I'll cover the diamond real quick just so that it makes sense. Let me just bring up a whiteboard here real quick. Share whiteboard. All right, so let's go with purple. I like purple. Red. Red. Ignore how badly drawn my diamond is. So we're going to say this is the anterior surface of the body. This is the posterior surface of the body. I'm actually going to switch cameras so you can see me. There we go. So when we're talking about this, these are our abs. These are our quads. These are our hamstrings. And these are the erector spinae. Here's my PSIS. Here's my ASIS. Oops. I did it on purpose to try to make some of you laugh. I appreciate it. I hope I made some of you laugh. So, when I go into anterior pelvic tilt, my ASIS is going to tilt down. My PSIS is going to tilt up. And we're going to hit this further, so don't totally freak out if you're not understanding that. When that happens, what's going to happen to my quads? Are they going to lengthen or shorten?
Shorten.
They're going to shorten. Good. All right, so they're going to become shorter. What about to my, oh, that, what? Stop. That's exactly what I intended to do there. Right, so they're going to shorten. What happens to my abs then?
Sorry, Mr. McKeever, which way are your hips going for this one? Is it?
We're going anterior pelvic tilt, APT. So my ASIS is tilting down. So if my quads shorten, what's going to happen to my abs?
Lengthen.
Yeah, they're going to lengthen. Here's the trick to this diamond. It is a great diagram. Thank you, Stephanie. I came up with this myself. No one ever taught me this at all. I'm just joking. Here's a trick to this diagram. Whatever happens to the abs, the same thing happens to the hamstrings. Whatever happens to the quads, the same thing happens to the erector spinae. So that means my erector spinae is going to be short or long?
Short.
Short, just like my quads. And then my hamstrings are going to lengthen out. In that process, I'm going to get that lumbar lordosis, that sway back. Right? Because all these are now tight back here. Right? Does everyone understand what I'm getting at with this? Does it make sense?
What is this diamond called?
So I just call this the pelvic diamond. I don't know. I call it the pelvic diamond. It's not the way I was taught it, but this is what I've come up with to try to make sense of it in my own brain. So yeah, call it the pelvic diamond if you want it. Pelvic girdle, pelvic diamond. Technically, this is a pelvic force couple. Whatever happens to the quads, the opposite happens to the abs. So same side, go opposite, opposite side, flip. I'm going to cover this one more time here just to make sense. So let me clear some of these. I wasn't planning totally on going into this, but some good questions led to this. So look at me with the fancy eraser.
Mr. McKeever?
Yep.
I forget exactly what it's called. We went over it with Dr. Johnson, I think, in kinesiology. It's something with passive and something motion.
Passive and active insufficiency?
Yes.
Okay. Yep. I'm going to add that in right now, actually.
Okay, thank you.
So again, I'm going to talk about just the anterior here to start. So my pelvis is pulling this way. My PSIS is pulling this way. What muscles are working in a force couple going into active insufficiency in order to make that happen?
Quads.
The quads, and what other one?
Erector spinae.
The erector spinae. So they are both going to get shorter and go into active insufficiency to go into anterior pelvic tilt because they're going to get shorter, right? Now, because they get shorter, two things can happen that will limit our range of motion with this. One is active insufficiency. The quads can't contract anymore. The erector spinae can't contract anymore. That would be true active insufficiency, right? The other thing that could happen is passive insufficiency of the abs or the hamstrings. If you had to hazard a guess, just knowing the general population, it is a product of sedentary lifestyle, yep. What muscle do we know is tight on most people?
Hammies.
Hammies. Yeah. So reality, what limits us going into anterior pelvic tilt is the hammies just can't lengthen enough, if that makes sense. Does that make sense to everybody? Because they're already super tight. So this really does help with somebody that's got shortened hamstrings because we can kind of stretch it out passively and put them into that passive insufficiency. So these two here are committing passive interference, or PI, passive insufficiency. These are going into active insufficiency. This actually is tying into more of my lesson than I thought it was.
Is there such a thing as because you know how like when like they're teaching you how to lift and you're supposed to arch your back, whether you're doing deadlifts or squats, that could lead to like a hyper anterior posterior tilt or anterior pelvic tilt?
Yeah, for sure. You know what else can lead to it is people wearing weight belts. Because when you have that weight belt cinched, it kind of forces you almost into anterior pelvic tilt because it's forcing a hyperlordotic curve. Now, why do we want that hyperlordotic curve? So if I put my low back into active insufficiency, that means I don't have the ability to lift with my low back.
Okay.
So what is that going to prevent?
Back injuries.
Back injuries. Good, right? You guys just did yesterday with Dr. Sokel, I think, some posture or some lifting, right? Techniques. And so if you tilt that anteriorly and get that little bit of extra lordotic curve, you can't lift with your back anymore. Your only option is to lift with your legs. That's why they do that. It's to make sure that you're not lifting at all with your back.
So if we are treating like, let's say, athletes that that's been doing that for a while and they have kind of hyper anterior pelvic tilt, just kind of work our way back to posterior.
Yep. We're going to work posterior tilts.
Okay.
Yeah, you are like right on the right path here, right? I'd be willing to bet most of us, if we work posterior tilts, it probably feels good. Because again, it's like Anthony said, a product of sedentary lifestyle. The one thing I've noticed, so my chair that I have right now, I don't know how much you guys know about this chair that I have that's really super duper expensive. This is the Razor Isker chair. This chair is $500. I got cheddar, man. No, actually, I saved up quite a bit to get this. There's a reason I bought this chair. And it's because of, number one, it's got an active lumbar support. And the other thing is when you sit in it, it puts you into posterior tilt. Right? And most chairs are kind of flat. And so you kind of lean towards that anterior tilt. This one, when I sit in it, puts me into posterior tilt. And then the lumbar support takes care of my lumbar curvature. And it really does. I mean, for sitting long periods of time, this chair by far makes me feel much more comfortable than my cheapy chair that I have for gaming. Yeah, well, here's a secret, Truman. The Secret Labs chair and the Razor Isker is pretty close. It just doesn't have the active lumbar support. That's it. Herman Miller's are nice chairs too, yeah. All right, so we talked about, are we understanding anterior pelvic tilt? Fairly well. And we're going to go over this again. So if you don't quite get it, we are going to hit it again. So don't totally freak out yet. Because I know I can feel Brooke a little bit there. Brooke's like, I'm not getting this. I don't understand it. Don't worry, Brooke. We'll get it. I promise you. Or maybe it's Diane. I'm not sure. Maybe they're both sending me the messages. Okay, we'll finish with pelvic tilt and take a snack here. All right, posterior pelvic tilt. Now my ASIS is going which way? Up or down? That's Daniela's freaking out. Okay, good. Thank you, Danielle.
Down.
Posterior pelvic tilt, they're going up.
Oh, sorry.
Sorry, let me.
Got the wrong one.
Yep, that's okay. So let's erase that. I probably messed you up because of that. So now we're doing PPTs.
Okay.
So now my ASIS is going up. That means my PSIS is going down because they are working opposites, right? So what two muscles are going to work as the force couple going into active insufficiency to make this motion happen?
Hamstring and abs.
Good. Hamstring, abs. So when we do a posterior tilt, like I think it was Stephanie that asked me about this before, about engaging your abs. For posterior tilt, you are engaging your abs, right? Because it's helping to pull that ASIS back. So if these two are in active insufficiency, which two are in passive insufficiency?
Erector spinae and quads.
There you go. Good. Do you see how easy those questions could be to answer? I know it looks hard, but honestly, if you just draw it out, it gets easier. Draw. That's a Pennsylvania word for you there. You draw it out.
Is this something similar to what we can see on the boards if, like, say these two muscles working together are the force couple, what two are?
So I'll give you a board question here. We'll write one out really quick for you. How about that? So your patient is performing, so we're doing posterior right now, a posterior pelvic tilt. The force couple working in this exercise is the, let's say, abs and hamstrings. Which muscles are likely to go into passive insufficiency?
Erector spinae and quads.
Good. So, well, I'm going to go. So what you'll have down here is you'll have erector spinae, quads, something like this. This would be what the question would look like. So you have three muscles that are part of the group there, right? And then you have one that you're looking at it going, why is that even here? What does the plantaris have to do with pelvic tilt? And what that does is that causes Bianca to get on this train that she's thinking for like 2 minutes going, why is plantaris on this one? That's it there. That's why it's there on purpose. It's there to confuse you, right? So what you'll do is you go, well, you know what? Looking at this, that has nothing to do with it. So we're going to cross that one out. So we're down to these three choices. What do we know about the iliopsoas and the quads? Do they work together or separately?
Separately?
For this portion, for doing this motion with the pelvis, they're actually technically working in
Together.
Yeah, because the quads are up here and so is the iliopsoas. The iliopsoas is right here, right? So technically they're working together. So you can't separate them out. So that's when you go, nope, those are the wrong answer. My only answer left is erector spinae. Or what I did for these questions is I literally drew this diamond because this made sense. If I could say, oh, okay, so my patient, let me see here, looks like this. Because my pelvis is pointed up. Right, so these are long, short, and then I just labeled my muscles. I went, oh, this is ES, this is HS, quads, and then abs. And I'm like, oh, look, that's one of the long muscles. A long muscle is passive insufficiency.
So, so the only reason why, like, the erector spinae is the better answer, it's because the quads work with the iliopsoas?
Yep. Yes. That was why I threw that on there. Because you can't differentiate between these. Now, if it had instead A, erector spinae, B, hamstrings, C, abs, and D, plantaris. Now, obviously, that's a lot clearer. Does that make sense?
Mm-hmm.
But because these two are on here are so close together, you can't separate them out. The one that's the best answer is erector spinae. Does that make sense?
I'm confused with the iliopsoas and the quads.
Okay. So iliopsoas and quads are on the same side of the pelvis. Right? What is the iliopsoas' job?
I think like flexion, trunk flexion on hip with
hip flexion is the primary job, right? What part of the quads does hip flexion?
Femoris.
I heard it, rectus femoris, right? Because when you say quads, you have to include rectus femoris. If it just says vastus group, it's different, right? Because vastus group never crosses the hip, so that one's automatically out anyway. That has nothing to do with this. But because when you say quads, it includes rectus femoris and iliopsoas work together to do that hip flexion. I wanted to make that one specifically difficult. You're probably not going to get one like this. This is probably more the likelihood what you'll get. Or maybe you won't have erector spinae, maybe you'll have quads.
So in this like type of question, pay attention to what works together and do process of elimination.
You're exactly correct.
So if two muscles are doing the same thing, that's a cue that
it's out.
Okay.
Like let's say I was talking about the shoulder, and I don't know, I was talking about what muscle is responsible for slowing down moving into abduction. And I said, and I had the supraspinatus and middle deltoid, because they work in conjunction, you can't separate them out. Those are both out. Does that make sense? Or if I talked about biceps and talked about, and the brachialis was on there, biceps and brachialis are too close to each other. Those are probably out. We'll get more into the test taking stuff like that, but I just wanted to throw a really trick one in. Again, most of the time it's going to be like this other one here, where it's going to be quads or erector spinae, hamstrings, abs, and then some weird muscle. Like I saw one where I was talking about pelvic tilt, and it added in the, what is it, flexor carpi ulnaris. What? Oh, that's, if your flexor carpi ulnaris is down here in your hips, you've got problems. I'm just saying. All right, do we need a break? Sounds like everyone's getting a little fried. Is that a yes? Okay, so I'm going to pause the recording. All right, so we're back from break. I did type a question in the chat while on break just because I wanted to use this as an example, kind of talking about what I was just talking about. When you talk about muscles that work together, that would automatically kind of rule out a grouping of them in a question. So the question I was looking up has, which of the following muscles work as a force couple to produce shoulder internal rotation? So when we're talking about force couple, again, we're talking about muscles that work together. A is pectoralis major, B is pectoralis minor, C is subscap, and D is teres minor. So what do we know about pectoralis major and minor? Do they work in conjunction with each other? Where are they located at, first of all? I hope you know where they're located at. They're located in your
upper chest.
Upper chest, right? Now, their fibers aren't completely in line with each other, right? But they do work together in doing kind of your chest motions, right? So yeah, those work in conjunction with each other. Even though they don't do the perfect same motions, they work in conjunction with each other. There's only one muscle there that is an internal rotator. Which muscle is it?
The minor?
Teres minor does what? Teres minor does what?
Elbow and shoulder.
Flexion, rotation.
Yeah. So teres minor does external, right? So this is what I'm saying. So pec minor does do some internal rotation. That's why I put it on here, right? But which one's the better answer for this? Subscap is your primary internal rotator. That's in here and that pulls it this way. I'm confusing a lot of people and I see Jason's face. We'll do more of these questions. I just wanted to add one because, again, pec minor, pec major, because of where they're located at, because they're grouped together, pec minor wouldn't be the best answer there. And when we talk about true rotation, we're only talking about 4 muscles. What are the 4 muscles we talk about when we talk about true rotation of the shoulder? Does anyone remember the acronym for it?
With the whole rotator cuff?
SITS. Yeah, there we go, right? So SITS makes up, what are the 4 muscles?
Spinatus.
What'd you say?
Supra, infra.
Natus.
Supra, infra, teres, minor, and subscapularis. Good, right? That's the SITS muscles. I'm going to say, here, I'm going to give you one hint here. That grouping of muscles got a student removed from clinicals once because she couldn't remember the SITS muscles after 4 weeks. So yeah, I saw that mouthing there, Riley. Right? So just, that's an easy one to remember, honestly, guys. And honestly, I'll be honest, the student did come back and then did better in the next clinical, but when you think about that, if you aren't able to do the rotator cuff on your 3rd clinical, yeah, you probably don't deserve to pass. Would you agree with that, Jason? Yeah, right? Especially if you're an outpatient clinic. Yeah, that's kind of important. So we'll hit more of those. Let's finish out these exercises real quick. I'm going to switch cameras again because we got to get through these. So USB video device. There we are. I got to tilt it back down again. There we go. All right, so we did posterior pelvic tilt with marching. The next we're going to do is bridging. So with bridging, what am I going to do? Don't even worry about the pelvic tilt right now. What am I doing with bridging?
Lift your butt up.
Lifting my butt up. There you go. Good, right? I always say you're going to lift your butt to the sky. So with just a regular bridge, I'm literally just going to put my feet nice and flat, hands out to the side. I can pull them in if I want to challenge it more, but I like to have the patient hands out to the side. And they're not pushing through the arms. Don't let them do that. That's cheating. They're just lifting the pelvis up and coming down. What do you think is the most important part there? The lifting up or the coming down?
Probably
Coming down.
Good, because coming down is what type of an activity?
Eccentric.
Eccentric.
Good. I can't see you guys right now because I'm kind of flat. So now we're going to posteriorly pelvic tilt. So I'm going to tilt back. I'm going to hold it, bridge up, and hold my feet flat. And then I'm going to come down. Now I can hold up there as an isometric hold if I want. But most of the time, what my goal is just holding that posterior pelvic tilt the whole way through it. And I relax. So the first thing I do is posterior pelvic tilt, bridge, hold, and slow down and relax. And you can see the pelvic tilt come out of my hips when I come down. Because watch, so now pelvic tilt, lift, hold it all the way down. And then when I come out of my pelvic tilt, I kind of rock, my hips kind of flop, right? So posterior pelvic tilt, up, down, I'm good. All right, I heard a question. No question? Okay, good. Now, bridging with kickouts. Now we're making it harder. So what am I doing now, do you think, when I come up? It says it on it. Give me a hint.
Extending one leg.
Yeah, right? Because you can't extend both, just to let you know. I had a patient try that once. It doesn't work very well. So now I'm going to get my feet nice and flat. I'm going to posterior pelvic tilt. I'm going to lift up, kick, and I can come down and do it again. Or if I got somebody that's advanced, I can get them up here holding that pelvic tilt. and kicking out.
Rockets.
Exactly. The goal, though, more than the kickouts and more than the bridge, is holding that pelvic tilt. So if you notice that they're coming out of the pelvic tilt, what should you do?
Have them start over.
Yeah, stop and reset. Still count the reps, okay? But say, okay, we got to stop, we've got to reset. Let's get that pelvic tilt back in there and reset. I don't know why I put the kickouts ahead of the marching. The marching's easier. So again, with marching, going to pelvic tilt, bridge, and I'm just going to march. Oh, I lost my pelvic tilt. Come back down, reset, pelvic tilt, bridge, march. Now, I could just as easily do that here without the bridging. I could pelvic tilt and just march here as well, if the patient's not getting that bridge with pelvic tilt.
When you're doing the different marching and bridging with PPT, when they come down, is it okay if they come out of PPT?
Yeah, let them relax a little bit. Give them a few seconds out of it because their back's probably tight. Right? So by doing that, that lets them, okay, I'm reset. I'm ready for my next one. Does that make sense? Because holding that pelvic tilt is really difficult for somebody that's got low back pain. You know, I've got low back pain, and this is one of the ones I do a lot, is just sitting here and holding that pelvic tilt. Do we understand the kind of holding that motion, moving? There are all kinds of stuff we can do. Now, if I want to make this harder, I can put my feet up on a Swiss ball. So I'm going to use my razor box here, actually, if I can get myself tilted. So now I can come here, pelvic tilt, bridge, and back down. And I can do all of the same exercises. So I can come here, kick out. I can do marching. So I can do all those exercises if this was a Swiss ball. I don't have a Swiss ball, one of the big balls. Okay, now that my back is sufficiently inflamed. There we go. Lower trunk, okay, question?
I do. So those are for back pain?
Absolutely, yep.
Oh, and then like for hips?
For hips, it could be for hips. I've had patients that have that have had hip surgery like a year ago. I use these a lot with them.
Okay.
Because again, we're mobilizing the hip when we do that, aren't we?
Yes.
Yeah, and it feels good.
Okay.
I could do all of those in seated as well. So let me bring my chair back over here, right? So I can get here. I can posteriorly pelvic tilt and march. I can posteriorly pelvic tilt and do long arc quads. So a person could do this where?
At their desk.
At their desk, yeah, at work, right? All right, last two exercises are probably the first one, lower trunk rotations or LTRs are ones that patient likes. The last exercise is the one that patients don't like, the crunches. So, lower trunk rotations. The patient's going to lay down again. We're going to posteriorly pelvic tilt. Their feet are going to be together, and what are they going to do? Does anyone know what a lower trunk rotation looks like?
Do the knees go side to side?
There we go. Yeah, knees just go side to side. Holding that posterior pelvic tilt. Holding that posterior pelvic tilt. Holding, okay, I'm starting to lose it. Recenter, posterior pelvic tilt. Holding, and rotate. That actually feels really good. And I'm just doing rotations. Again, this is another one some clinicians call wig wags. I just tend to call wig wags the ones I'm doing with like the feet. So these are just LTRs for me, lower trunk rotations. All right, crunches. 90% of people that do crunches do them wrong. What are some of the mistakes people make doing crunches?
Like they're kind of straining their neck or they don't engage their abs before they start.
Good, yeah. How do people strain their neck? tuck their chin too much? Good.
Yeah.
Yeah, they put their hands behind their head, right? And instead of engaging the core, they pull up with their arms, right? And when you do that, that puts a ton of strain on your neck. So how can I avoid that? What can I do with my arms?
Across your chest.
Across my chest, right? And depending upon if I'm working, like I've worked with martial artists and MMA fighters and boxers, sometimes instead I'll have them kind of hold them in guard position. So now they definitely can't use their hands to pull themselves up. With a crunch, how far am I coming up?
Just so that like your like shoulder blades are just coming off of the ground.
Good job, right? So literally when I'm doing a crunch, this is the way you see a lot of people trying to do a crunch. Right? That's more of a true sit-up. And again, it's not that sit-ups are bad. Sit-ups are okay. But for this, we're working more with a patient that's got low back issues. So we're going to do that posterior pelvic tilt. And we're going to come here. And I tend to hold my hands out to the side because that's the way I was always trained. I'm just going to lift my shoulders off and come back down. Notice I'm not doing this with my neck. Right? I'm not doing chicken head coming up. Head stays stable. Shoulders off and down. What muscle am I primarily working?
Your rectus.
Rectus abdominis.
Good. Can I isolate different components of my rectus abdominis? Okay, I see some people saying yes. How?
Like if you lower your, like if you do like leg drops.
Okay. I can work the lower. So when you isolate, the most you can really do is isolate upper component versus lower component, right? You can't isolate in, because I've seen exercises. Oh, you're going to isolate the top quarter of it. No, you can't do that. The most you can do is isolate the upper and the lower component, right? You can't truly isolate individual segments of it is what I'm saying. Just don't buy into that. Hey, the ice cream truck's here. Squirrel. But yeah, I could do leg raises where I pull my, reverse the muscle action of my rectus abdominis, right? Good. Again, with the crunches with posterior pelvic tilt, the most important part is that posterior pelvic tilt. If they can't lift very high, that's okay. They can work to it, right? What if they have to push up a little bit with their elbow the first couple times they do it? Hey, yeah, let them, right? Especially when I work with kids, because kids don't do this a lot. Those of you that have kids that have struggling with at the gym, maybe in school, they're having problems, they have to do 50 sit-ups at school. Start them using their elbows to help them up first. And then gradually take the elbows away. That's the way you can build up to doing this. So I could come here and I can keep my elbows kind of here, give me a little bit of support with it. Right? And then eventually take one elbow away, take both elbows away. But again, the main part for this that most people make the mistake of is the neck. All right. Oh, my back. My back is killing me. Are there any questions at this point? So again, are those all the exercises you're going to encounter in the clinic? Not even in the least. So the next question I usually get is, Mr. McKeever, where are all the arm exercises? Is anyone thinking that? No? Where do you think all the arm exercises are?
TherEx 2.
Yeah, TherEx 2. Good. Now we will hit a few before you go on clinical. So we'll hit a couple basic shoulder exercises so you know, so you're not totally out in the wind when you go out to clinicals, okay? So don't totally freak out yet on that. But TherEx 2 is focused on upper extremity because Dr. Ovreskin is specialized in upper extremity and arms and hands. So I kind of let her deal with them where I'm a little bit more core and lower body specialized, if that makes sense. So don't totally freak out about that. Are there any questions on the exercise? OT, I love it. Anthony, thank you. You gave me a little humor for the day. Are there any questions on that? So with those TherEx, do you feel, if I was to tell you tomorrow that we have to go to class and teach them to everyone, how would you feel with that? Could you possibly pull most of them off? Yeah, right? They're not hard. And again, a lot of people will say, well, these are really easy, right? Truman's looking at these like, those are just so easy. Why are we teaching these? Our patients aren't us, right? You're dealing with 96-year-old Bob who was a mailman for 50 years and is now seeing because he got low back pain. You know, Truman may be able to go and do like wall push-ups where he's standing on his hands, he's got his feet up on the wall and being able to do push-ups. But Bob's not able to do those, right? Bob's barely able to get out of a chair. So those are the people we're working on. Now, if we work with athletes, do we have to modify all of these? Absolutely. Right? If you get into working with high-end athletes, you know, one of the places, the company that I worked for back in Pennsylvania, we were the therapy and also rehab team of the Harrisburg Stampede, which is an indoor football league, right? So it's most of the people that can't make it to the NFL. Just saying. Right? And so all those guys were a different breed of people to work with than Bob, right? Because a lot of them had strength and ability and agility. Yeah, heel slides and all those hamsters and heel slides are hard after ACL surgery. You're right, John. It's amazing how difficult something simple like that, or even just a meniscectomy where literally they go in and cut a piece out. It shouldn't affect your knee, but it does. All right, so we survived that. So now let me grab something real quick so I can look a little more presentable. Uh-oh. Camera. Too many switches to the camera. There we go. There we go. Now I look more teacher-like. All right, so that's going to be it for TherEx. We are now going to switch gears. I know I had a range of motion lecture. We'll catch up on it. Don't freak out about that. We'll catch up. I built in extra days in case this took a little bit longer. We're now going to start with the new lecture that I just posted from Kanice on gait. So let me bring gait up here.